Okay, when we talk about diving injuries, just a couple of quick things about diving injuries. Remember that they're broken into two types. We have type 1 and type 2, and DCS is decompression sickness. Type 1 decompression sickness, the big thing that we see with these patients is they get mild skin pain, they get itching, and they get like a skin rash. Type 1 DCS, a lot of times, is basically just a dermal response or intradermal response, a skin response, if you will, to gas trapped underneath the skin. So again, what we see is the patient gets skin pain, they get itching, and they get mottling or marbling underneath their skin. When we talk about type 2 decompression sickness, this is when a patient actually has trappage of air in the, or gas, I should say, in the vascular space. So when we talk about type 2 decompression sickness, the symptoms depend on where the gas emboli is. So for instance, if the gas emboli is somewhere in the head or the neck and it's occluding blood flow to the brain, we're going to see neurologic problems. So those neurologic problems can present themselves because of gas emboli occluding blood flow to the brain, or they can also occur because of a decrease in blood flow to the spinal cord. So we can see essentially any neurologic symptoms with type 2 neurologic DCS. So the patient may be altered, the patient may be confused, the patient may be combative, the patient may present like a spinal injury, like a spinal cord syndrome, with some kind of weird symptom mix where they have feeling in one part of their body but not another part, or they can feel in one part of their body but not move that part of their body. The neurologic presentation is essentially endless. Some classic things that we see with these patients, a lot of times they will have a headache, a lot of times they'll have visual disturbances. It's classic that they'll have some kind of change in their level of consciousness. And then the other thing that we see is a lot of times they'll have problems with their gait. And the classic thing that you'll hear divers talk about is what's called the staggers, or what they call labyrinthine DCS. This is where the patient has lost the smooth muscle control of their body because that part of the brain is hypoxic because of an air gas emboli. Now, if the gas emboli happens to be in the respiratory system, then the patient obviously is going to present like somebody who's got a pulmonary embolus. We'll see a lot of times that the patient will have burning substernal chest pain, they'll have frank shortness of breath, they may be severely hypoxic, severely hypercapnic, and oftentimes that will be refractory to oxygen. Finally, the third thing that we can see with these patients is we can just see frank hypovolemic shock. And there's a lot of debate about where that hypovolemic shock comes from. Some of it we believe actually comes from the fact that when patients are breathing on positive pressure, it tends to dehydrate them. And if you've ever scuba dived before, you know that scuba diving is actually one of the things that actually causes us to become quite dry. You would think, well, you're in an ocean environment or a water environment, that wouldn't be the case. But actually, like I said, if you've ever scuba dived before, you know that it really, really dehydrates you. Now, when we talk about air gas emboli, remember that when we talk about an air gas emboli, the physiology behind this is that we have some amount of gas in the lung, and as we go up up towards the surface of the water, that gas is going to expand. As that gas expands, it translocates across into the vascular space, and then it's off to whichever part of the body to cause what havoc, whether again it's the neurologic system, the respiratory system. We can even have air gas emboli like in the coronary arteries that cause MI symptoms. So it could be that translocation of gas can kind of end up anywhere. Now, finally, when we're talking about diving emergencies, we know the big thing for those patients is they need to be repressurized. If you are not sure where to go, or you need some direction about how to manage these patients, you need to know what DAN is. DAN is the Diver Alert Network. It's a poison control type model where you can call in 24 hours a day and you can talk to a medical staff who's experienced with dealing with dive emergencies. And it's actually hosted by Duke Medical Center over on the East Coast. Again, they're available 24 hours a day, and there's the number there. For the purposes of an exam, you don't need to know the phone number, but it's there just kind of for your general information. You do need to know what DAN is and what they do. Okay, when we talk about treating these patients, the big thing obviously is 100% oxygen right off the bat. If they're obtunded, they can't protect their airway, or you expect that their clinical course is going to deteriorate, we need to think about intubating them. Again, we always want to give these patients fluid to assure normal volemia. There used to be this thought process that with diving emergencies, one of the things we want to do is we wanted to put these patients in a Trendelenburg position. That is not the case anymore. We do not put these patients in a Trendelenburg position. Remember, just put these patients in the position that you need to put them in to manage them. Some other things that we want to consider: it's not uncommon when people have a significant diving emergency for them to also sustain a pneumothorax, so we want to really be watching both sides of their chest, and we want to treat any pneumothorax that presents itself appropriately. We want to give the patient aspirin to prevent coagulation, and then obviously the patient needs to go to a hyperbaric chamber for definitive management.
I'd come for you.